Hello, everyone, and a very warm welcome to all of you. Thank you for joining us for Arthritis Talks, non-surgical approaches for arthritis treatment. I'm Dr. Sean Bevan, Chief Science Officer at Arthritis Society Canada. We've come together for this event from many different places. I would like to take a moment to acknowledge the land that I am located on and on which our Toronto office stands. And this is on the traditional territories of the Mississauga of the Credit First Nation, Anishinaabeg, Huron-Wendat, and Haudenosaunee Indigenous peoples. Today, this meeting place is home to many First Nations, Inuit, and Métis peoples, and I'm very grateful to have the opportunity to work and live with my family on this land. Many people living with arthritis think that medication and surgery are the only treatment options for arthritis. Now, in reality, there are many options available that don't actually involve surgery. Tonight, Dr. Ko will discuss a number of these options with you. Now, before we get started, a few logistics. This webinar is best viewed on a laptop or desktop computer. If you have any technical difficulties, please email arthritistalks@arthritis.ca for assistance. If you have a question for our presenter, you can submit it through the Q&A button, which is at the bottom middle of the screen, and we'll try to get to as many questions as possible during the hour that we have together. You can click on the chat icon also on the bottom middle of the screen to access the chat and connect with other participants and our chat moderator. Now, if you find that distracting, you can close out of that completely. Just click the red X icon out the window. We're also pleased to continue to provide captioning of our webinars to accommodate the diverse needs of our audience. So you'll see that running along the bottom of the page. So many questions that we received followed similar themes in advance, so we will look at those first before going into a live Q&A. And before we get started, I have to thank our event partners, Pfizer, United Way Winnipeg, and others for their financial support of our Arthritis Talk series. So with that, first, a very warm welcome to today's expert, Dr. Gordon Ko. So, Dr. Ko, could you just start off with giving us an overview of what integrative medicine actually is?
Well, I'd like to first start off by thanking you, Dr. Bevan, for moderating this webinar. I really appreciate all the background work you and Ashley Croning, our Senior Mission Director for Arthritis Society of Canada, have engaged in with a vision of improving health for Canadians, especially the 6 million of us affected by degenerative and autoimmune arthritis. So let's start off tonight's session by first defining integrative medicine. Integrative medicine is non-mainstream medicine, not just drugs and surgery. It is also not just alternative medicine used in place of drugs and surgery. And it is more than just adding complementary therapies to conventional drugs and surgery. Integrative medicine, according to the NIH, is a coordinated approach with complementary and conventional treatments that is holistic, patient-focused for long-term health and wellness. Now, another key concept to understand is the science that leads to integrative medicine becoming mainstream medicine. First, we usually start off with RWE on the left there, real world evidence, which is what we observe, what our patients and people like you in the audience are seeing is helping them. And it then leads to larger population studies, typically done by our epidemiologists. On the other side of the triangle is what our scientists are doing in the labs to help explain how things work. This may include animal studies, human studies with advanced brain imaging, DNA mapping, but really to get things mainstream, like into our hospitals, we need the gold standard of RCTs, randomized clinical trials. These are studies showing that one group of patients getting an active treatment are better than the other group, a matched group, getting a placebo or standard of care treatment. The challenge with all of this is it takes time, often decades, because it requires all sorts of agency approvals, like ethics review boards, and it requires money, often hundreds of thousands of dollars, to get these trials completed peer-reviewed, published, and then taught in medical schools, and then endorsed by the College of Family Physicians and the Royal College of Specialists in Canada. Well, I'm here to share with you about 3 emerging areas that are indeed backed up by RCTs. And I hope it will help you now, not decades later, with your arthritis and autoimmune condition. So these 3 areas are, number 1, regenerative medicine, harnessing your own blood to heal. Now, I've thrown in a few extra slides on this because so many of you in the 6,000 registrants here have sent questions on this. The second area is functional medicine, looking for and treating root causes. I have a new acronym called FITE, F-I-T-E. And if you stay with me, I'll tell you what this stands for to help with root cause medicine. The third area is that of neuroplasticity, the concept that the brain can change and heal itself. With the latest updates I'll be giving you on how medical cannabis can help with this. Now, there are already 4 archived webinar videos on medical cannabis in the Arthritis Society of Canada's website that you can watch for more details. I don't want to repeat a lot of that information. There's also webinars on complementary medicine and nutrition that you can also look at for more detail. And these are all great resources to share with your friends and family, as will this archived talk, which will be available tomorrow. So I have a 3-minute video clip of what happened over 10 years ago in our approach with platelet-rich plasma. Can we play this, Ashley?
It is being called a breakthrough treatment by the Canadian doctor who pioneered it. A way to speed the healing of painful injuries such as aching joints, sore backs, and necks. And it is so successful. It's the choice of professional athletes, and best of all, it's completely natural, with no need for prescription drugs or surgery. CTV's medical specialist Avis Favreau has more.
Ruth Grant is back on the run after suffering an excruciatingly painful back injury.
I felt something snap in my buttocks, and I thought, oops, what have I done?
After a year of unsuccessful diagnoses and treatments, her pain finally disappeared, and the solution, not drugs or surgery, but a vial of her own blood.
And literally in 4 weeks, I said, wow, I'm flexible, I'm moving.
It's called platelet-rich plasma therapy, and pain specialists like Dr. Gordon Coe are intrigued by its potential as a drug-free treatment for many joint and back injuries.
You know, we're moving away from just using just pharmaceuticals to relying on the body's own healing mechanisms.
A vial of blood is drawn from the patient. It's then spun in a centrifuge to separate the plasma. That is then injected back into the patient's injured joint.
Touching a bit of the bone, Alan, feel that?
Doctors say that in that plasma are very high concentrations of platelets.
And that's the actual needle going in there.
Cells that appear to marshal the body's system to repair muscle, bone, and ligaments.
Those platelets then have growth factors, and those growth factors are what the body uses to heal tissue.
This is a breakthrough type of approach.
Al Rhodey is hoping it will erase his constant back and neck pain.
Nothing has worked for me, so I have nothing to lose in trying this procedure.
Scientists around the world are studying plasma therapy's ability to treat shoulder strains, ligament tears, even bone fractures, and trying to understand why it doesn't seem to help about 20% of patients. And because it's experimental, it's not covered by provincial health plans and costs about $700 per treatment. Doctors say some patients need several injections. Ruth Grant only needed one, enough to put a spring back in her step. Avis Favreau, CTV News, Toronto.
So now, in Ruth's case, besides the severe arthritis that she had in her back, as well as a previous fusion in her lower spine, she had a ligament injury problem. And we often see this, well, we may see this after injuries, like a person seatbelted and they're in a front impact car accident or side impact, or they have a fall on their buttock. So when muscles, as you can see on the right side of the slide, when muscles are injured, as you can see in the red, muscles typically heal well. They have very good blood supply. You can exercise them, you can stretch and strengthen them. Ligaments in the blue are a different type of tissue. They're sort of fibrous bands that join bone to bone. They have very poor blood supply, and if they're badly sprained or even torn, they often do not heal back fully. In Ruth's case, her SI joint, her sacroiliac joint, was loose. It was unstable. And despite trying extensive therapies and other types of injections, it just wouldn't hold in place. And after the one PRP treatment with proper rehab, she was able to get her stability back and return back to playing tennis again. Now we went on to publish her case and other cases showing long-term improvements in both pain and disability, even up to 4 years on follow-up. And as you can see from my co-authors in this paper who help with these patients, it's an integrative team, including chiropractor, physiotherapist, and naturopath. It's not just do a one-time shot and you're good. These patients also benefited long-term by being treated, by being taught how to eat right, move more wisely, and sleep better, a recurring theme that I'll be emphasizing tonight. Now, since our publication came out, RCTs have sprung up documenting the effectiveness of PRP in chronic low back pain, applying not only to the SI joint, but also the lumbar facet joints, which are often a common site of degenerative arthritis. One study published just last year demonstrated the superiority of PRP over cortisone when injected right into the disc. Like the previous studies, both cortisone and PRP work well for the first month. But after this, the cortisone tends to lose effectiveness, whereas PRP takes over, showing better results 6 months and even up to a year later, as you can see in this graph here. This year, a review was done this year of over 2,300 published articles, including 13 good randomized controlled trials, supporting the use of PRP as effective and safe for chronic degenerative low back pain. It's graded as level 2 out of 5 levels for evidence for proof. Moderate evidence defined as being obtained from at least one relevant high quality RCT or multiple relevant moderate or low quality RCTs. And as noted in the comments, larger multi-center RCTs are still needed to make this a level 1 evidence type therapy. Now, you may be thinking about, what about osteoarthritis in my other joints? Well, for just 4 months ago, another systematic review came out supporting PRP for this. They included looking at 24 RCTs with 1,344 patients. And interestingly, they concluded that PRP, platelet-rich plasma, works for knee arthritis, ankle arthritis, and TMJ jaw arthritis. It did not help that much with hip arthritis pain. They also found better results when LP-PRP was used. LP means leukocyte poor. Leukocytes are white blood cells in the mixture. So if you can take away a lot of the white blood cells when you're injecting the PRP, you get a better result for osteoarthritis than you do with leukocyte-rich PRP, where there are a lot of white blood cells. Now, because of the questions that came out, and because you're interested, I thought I'd just throw this slide in. And this is a paper that, again, that just came out on how PRP is generated. In a nutshell, just using a regular centrifuge spin doesn't work. You need to use a special double spin centrifuge to separate out the platelets. And you can see that layered out in the top of the white layer called the Buffy coat. So injections into joints should have low red blood cells, high platelets. Some studies suggest 1 billion platelets would really be optimal, and low white blood cells. For chronic tendonitis, as this case report study on the right side shows, having more white blood cells in the injections into tendons and ligaments seems to be more effective. It stimulates something called angiogenesis and better healing. Another key concept to understand, well, why is 20% of patients not responding? Well, maybe they're taking things that are interfering with the PRP from working. So these are a list of drugs, supplements that you've got to stop, 7 days, 5 days before, and stay off for 7 days or so afterwards. of all the different medications, Tylenol is okay. But I wasn't aware of this until it was presented in November, that even cholesterol-lowering drugs like statin drugs have an anti-inflammatory effect, which can interfere with the PRP. So if you're going to be considering PRP, you've got to come off these medications. You have to check with the prescribing doctor that it's okay, especially coming off the statins or the platelet inhibiting drugs and aspirin, things like that. Now, if you've had a cortisone injection, the consensus is you have to wait a month before you do PRP. And if you want to do stem cell injections, which I'll talk about at the end, you have to wait probably at least 3 months before considering that. There's also emerging case studies now on the use of PRP in patients with rheumatoid arthritis, and a case report on a patient with psoriatic arthritis who was able to stay on her biologic drugs and still respond well to the PRP. So to summarize everything, in functional medicine, in regenerative medicine, platelet-rich plasma injections are an emerging level 2 evidence for chronic low back pain, for osteoarthritis of the knee, ankle, jaw, TMJ. There's some stuff on it being for shoulders as well. PRP is available in Canada and the United States, but is not considered mainstream in both of our countries for arthritis management. And in Canada, it's not covered by provincial health plans. Typically, what we try to do with our patients is we look at their coverage, and we actually would prefer that they do other treatments first. They'll do the cortisone injections, they could do nerve blocks, a procedure that's really good for back pain, spinal pain, knee arthritis pain, and hip arthritis pain, and shoulder arthritis pain after surgery where they've had a surgical replacement and there's still pain, is something called radiofrequency denervation. That's where you electrically ablate the sensory nerves that supply the joints, and you numb out the pain for about a year and a half, up to a year and a half. And it's all covered by the provincial health plans. And then if you have widespread fibromyalgia and neuropathic pain, some clinics provide OHIP-covered IV ketamine infusions. But we also use a lot of viscose supplement injections. The latest science suggests that it's the high molecular weight viscose supplements that work, like some of the ones that we prefer to use, such as Monovisc, Durolane. We do have one type of viscose supplement that's mixed with cortisone to help with the initial inflammatory pain called Cingal as well. And those are covered by extended health plans, and you have to look at it as a medical device to have it covered. And we've also published off-label on using Botox into joints for pain. The third point is for osteoarthritis. Remember, it's the low leukocyte poor PRP that's more effective. For chronic tendonitis, we want to have leukocyte-rich PRP that's more effective. And often patients will try some dextrose injections as well, where there's some RCTs demonstrating effectiveness. And don't forget that there is coming research looking at other autoimmune type of conditions, rheumatoid, psoriatic arthritis. And the adipose and bone marrow stem cells I will talk about towards the end. Now, if you're interested in finding a medical specialist for this, please look up the Canadian Association of Orthopedic Medicine, COM.ca. It's our national organization that trains doctors across Canada on doing these type of procedures. And there are also American organizations that do train, and if you need more information, you can let the organizers know, and we can certainly get more information to you through the CAOM. Now, finally, one other key point is there's no point injecting blood if the blood's not healthy. And this sort of leads into the area of functional medicine.
That's great, Dr. Coe. Thank you so much for that really, really thorough answer. So functional medicine, can you elaborate a little bit on how it can potentially benefit people living with arthritis?
Well, functional medicine really looks at getting the blood healthy again, right? There's that tree that I was talking about, right? And when you have the tree, you're trying to look at not just replacing the leaf that's rotted away with a new leaf. That's like doing a joint replacement. or taking painkillers to paint the leaf green again so it looks good. We have to do more things than that, and we need to look at getting at underlying root causes and looking at the soil for the tree. And this is really a whole area of medicine that was pioneered by Dr. Jeffrey Bland in the 1990s. So another way of looking at it is, here's a picture of a tree on fire. And if it's a small little fire, well, we can put drops of water on it to extinguish it, like use our typical medications that we like to use. If it gets bigger and the fire is getting more, then we need our rheumatology. I need my rheumatology colleagues to do the cortisone injections, the DMARDs, which is drug or disease-modifying anti-rheumatic drugs like methotrexate, for example, and biologic drugs like Humira and biosimilars as well. Because we don't want a wildfire to then destroy everything, destroy all the joints. The only challenge, though, is that if that's all you do, you may start to get problems with side effects. For example, if you do cortisone injections repeatedly over and over again, it's going to wear down, thin the cartilage, bone, and tendons, and it can make your blood pressure and blood sugar go up. So in functional medicine, what we try to do, on the other hand, is focus on the gasoline fueling the fire. And if you could just click that, you see the gasoline shoot up here. And again, the gasoline shooting up. And there's the gasoline that I would describe it as, you want to find the cause, the root cause. And there's FITE. There's food choices that affect the bacteria in the gut. I is stealth infections like Lyme disease, viral conditions, parasites. Long COVID syndrome could play a factor. Epstein-Barr virus being a big player with some conditions that are autoimmune. And then there are toxins that can build up in the body, like heavy metals, pesticides, mold toxins. And I wanted to add another one, which is E, for emotional traumas. Emotional traumas will bring up cortisol levels, and high cortisol levels in the body will wear down the immune system, wear down the body as well. So we need to identify really the FITE that's making our body go into a fight or flight mode. The sympathetic nervous system gets revved up, and it's not good for our body. It's actually hurting our body and causing more damage to our systems. Another key concept is that of the brain, immune system, and gut. We have strong laboratory evidence now, having mapped out the human microbiome back in 2017, that these systems are all interconnected. When we have bad bacteria in our gut, often from a poor diet, we generate inflammatory immune signals that affect our bodies and our brain. Signaling also goes up from our gut via the brain's biggest nerve, called the vagus nerve, that can further perpetuate a chronic pain state. Scientists state that the gut, in many ways, is our second brain. 99% of our happiness chemical, serotonin, is produced there. And over 50% of our reward chemical, dopamine, is also made in the gut. And on top of that, 75% of our immune system is housed in the gut. So we now know that if we can get healthier bacteria in the gut, starting off with a healthy diet, perhaps adding courses of probiotics and prebiotics and lots of fiber, and even now research on fecal transplants from healthier individuals into sick individuals, we can improve immune signaling and the brain-body connection. Likewise, engaging in mind-body therapies like mindfulness meditation, having an attitude of gratitude, and will, via the vagus nerve, promote the growth of a healthier microbiome. Lots of lab work showing this. And there's also real-world evidence coming out to the forefront now. And I threw this slide in here to just talk about this because it's relevant for the future slides. The UK Biobank, I don't know if you've heard about that, but this was started in 2006. They got 500 volunteers from the UK, and they had these volunteers fill out all these questionnaires, undergo physical examinations, including their vital signs, their lung vital capacity, their bone density, the intraocular pressure in their eyes. These volunteers gave their blood and urine samples, which were preserved to the point where in 2017, the DNA could be extracted and analyzed. And by that time in 2017, there had been about 1.3 million hospitalizations, 40,000 cancer incidents, and over 14,000 deaths, and autoimmune diseases as well. So the data is just exploding now on what's coming out, on what correlates with autoimmune disease and arthritis. So here's a study that was just published, 479,000 plus subjects with complete data from the UK Biobank, followed for 8 years. And they found this strong link with eating a Western diet, which is highly ultra-processed foods and high red meat, and getting new onset rheumatoid arthritis. Another study about to be published found a similar connection with knee and hip osteoarthritis. In fact, they sort of projected that if you could reduce your consumption of ultra-processed foods by 20%, there would be an overall reduction in the population of 7% getting knee osteoarthritis. Now, can you imagine the cost savings if we could reduce the need for knee replacements by 7%? That would be incredible. Ultra-processed foods, by the way, if you're eating that, you're 1.5 times more likely to have mental health issues. Eating ultra-processed foods is bad for your brain. Another study showed that if you could cut your ultra-processed foods, your risk for dementia goes down by 19%. And ultra-processed foods, for every 10% increase you eat in them, there are higher rates of cancer. And again, this is 197,000 people followed for 10 years in another study. So these studies have all come up this year and last year. So the number one rule in functional medicine and Gut Foundation is cut the crap. Take out calorie-rich, sugary drinks and all these things that you see on the right. Limit your alcohol consumption, which is now considered a carcinogen, to perhaps 1 drink a week. And they say for young people, try to not drink alcohol, period. Processed junk food with trans fats, MSG, the deli meats, get off them, right? And fried foods that are cooked in seed oils, which have high linoleic acid, omega-6s are not good for the body. Instead, we have to look at eating fresher foods, and I'll talk about that in a sec. And we also have to read labels. So if we're going to buy a snack to eat, look at what you're buying. Ideally, the snack should be under 5 ingredients. This one on the right has over 30 ingredients. It should be under 10 grams of sugar. This one has 17. It should be over 10 grams of protein. This has 3 grams. And it should be over 5 grams of fiber. This one has only 1 gram of fiber. And the carb-fiber ratio should be 5 or less. It's 34 to 1. It's way too high. It's going to cause problems like diabetes and other things that are correlated with autoimmune and osteoarthritis conditions. They're all pro-inflammatory. What can we do about it? Well, last year in the British Medical Journal, there was another study looking at 25,000 participants followed for over 5 years. And they found that the people who were taking vitamin D, not the placebo, this is a randomized trial. They were taking vitamin D, 2,000 international units a day, had a 22% lower risk of developing autoimmune diseases, not just rheumatoid disease, but lupus, Crohn's disease, Hashimoto's, thyroiditis, and with omega-3 fish oils, a 15% reduction. So I thought I'd show you some slides on what I do practically for vitamin D. Number one, you want to ideally titrate things based on blood levels. And if you can do your blood test with your family doctor. Now, if you have osteoporosis, malabsorption, or a kidney problem, it's covered by the health plans. But typically in Ontario, it's not covered. And the cost maybe has gone up from $30, I think it's $45, maybe a bit higher now. But it's a worthwhile investment to at least know what your baseline level is like. Getting your levels over 80, which is considered normal, is actually good for your bones. It reduces the risk for osteoporosis, and it decreases the risk for falls. Getting your level over 100 is actually good for reducing your risk for severe COVID, where you end up in the ICU or die. And getting it over 130, studies suggest you have a lower risk for the common cancers. So aim for an optimal level between maybe 100 to 170, according to some researchers. I like to usually quote Dr. Alan Gaby, G-A-B-Y, who's published extensively on vitamin D, and he says, the average Torontonian, where I live, should be taking 2,000 international units of vitamin D a day in the summer months, and in the late fall, winter months, where we don't get enough sunlight, 4,000 international units a day. Now, in my years of recommending this to patients, I have had a few patients actually reactivate their kidney stones. So if you have a history of kidney stones, be cautious, be careful. Don't ramp it up quickly. And as a general rule of thumb, I do recommend vitamin K2, which helps the vitamin D receptor work better, but it also drives the calcium into your bones and not into your heart, kidneys, or rotator cuff. There's research validating that. And you have to make a distinction. It's K2 as opposed to K1. K1 affects coagulation. We're not talking about K1 for if you're on warfarin, but we're talking about K2, which you can also get at most health food stores. And there's also the need for magnesium as well. That primes the vitamin D receptor, and it's important for chronic pain as well. Now, for omega-3s, look at the labels as well. You want to make sure you have a good quality product. And the first mistake people make is they just look at the total milligrams of omega-3s. No. You want to look at the milligrams of EPA, which is the active ingredient, really good for pain and inflammation, and the active ingredient for DHA, which is good for the brain. And typically, a good product will have about 400 milligrams of EPA, 200 milligrams of DHA in a capsule. But some of the bottles will say per serving, and then one serving is 3 capsules, so you're getting a more dilute form. So you want to get a high quality form. Stay away from the 6s unless you're malnourished or have anorexic or things. You don't need omega-6s. We have way too much of that in our diet. And the studies show that if you want to have an effect on inflammation, you've got to gradually bring it up to about 2,700 milligrams a day based on the randomized controlled trials published. So one of the questions I have about that previous study was they didn't probably dose the omega-3s high enough to get as much of a effect on preventing rheumatoid arthritis. Now, they do say that it can thin the blood, but I've seen this even with lower doses. So if you're having surgery, dental work, colonoscopy, if you're getting PRP, go off your omega-3s and stop it like 1 to 2 weeks beforehand. And if you want to check the quality of the omega-3s to make sure there's no mercury or DDT or other chemicals in it, there are some websites that you can check as well on that slide. So in terms of the functional medicine summary, we have to address root causes, starting with our lifestyle habits, really promoting a healthier gut microbiome. We want to be testing, not guessing, because I've had patients come in and they do everything. They think, oh, I've got a problem with Lyme disease. They do all this expensive testing out of the United States or Germany, and they end up going down the Lyme disease rabbit hole. And all it took was, with one of my patients, was getting a test done to show that they likely have the gene for celiac disease. The fellow went completely gluten-free and all the symptoms went away. So test, don't guess, but avoid rabbit holes. Right? Check with your family doctor, nurse practitioner, pharmacist, if you're on supplements and medications to avoid interactions. Learn to read labels. And another principle is to start with topical treatment for pain as opposed to pills and things that can affect the microbiome, as well as and inhalables that could affect your lungs, right? And if you want to hear more about some practical tips on eating right, moving more, sleeping better, we do have a podcast that my wife is also a physician. We both shared at the onechurch.to group on how to do all this. We don't have time to do it today, but at least you could check that out as well as a resource. And finally, finding a functional medicine doctor is really important. So check out the International Institute for Functional Medicine.org website and see which doctors have been certified and trained. It's not a weekend course. This is years of training that are close to where you live. So we really are moving for chronic arthritis, we're moving away from just synthetic foods to more natural plant-based whole foods. We're also moving for chronic arthritis towards more natural plant-based medicine.
So thank you, Dr. Ko. That was a lot of information. You did mention at the start, you referred to some of our previous medical cannabis arthritis talks. So really would encourage people, if they want to dive deeper into that subject in particular, to look at those. But given that we did receive so many questions in the context of you joining us, could you just speak for a moment about why some people living with arthritis might find some relief with medical cannabis?
So for those of us with arthritis and autoimmune disease, there's inflammation. The big player in the medical cannabis field is really CBD, cannabidiol. That's the key ingredient that has so many helpful effects. For example, it has effects neurologically. It's good for neuropathic pain. Often you have to add a little THC to really help with the neuropathic component, but starting off with CBD, and it modulates the brain as well, the neurological system as well. It has documented effects for arthritis, for what we call nociceptive pain. And it has studies documenting its effectiveness as an anti-inflammatory and its ability to modulate the immune system to really balance it out. Really, medical cannabis has effects for homeostasis, because we all have our internal marijuana in our bodies called the endocannabinoid system. And the endocannabinoid system helps to keep our bodies into balance. And the addition of CBD with some THC can really help with that, including anti-anxiety as well. So moving forward.
Right. So what would some of the side effects be that people should be concerned about with medical cannabis?
Well, I think the common side are really related to THC, which is the psychotropic component of THC, which is the basis for recreational cannabis. And just remember the 4 Ds: dizziness, dry mouth, drowsiness, and a decreased ability to react with a lower ability to concentrate. The 4 Ds are really quite common. And if you, again, take too much THC, you can get your recreational high, which those of us medically do not necessarily want. And taking THC in someone who's new can cause a fast tachycardia heartbeat. It can also drop your blood pressure. It can make your eyes red and give you a headache and some blurred vision. And there are some rare side effects if you overdo cannabis, like cannabis use disorder, which are listed there. But those are the common side effects that we typically see. But as a rule of thumb, what I do with my patients is, if they're under the age of 25 when the brain is still developing, I'm not happy just putting them on THC. I'd rather a specialist do that specializes in the condition that they have, who has a good addiction knowledge background, because you have to be wary about high THC in the youth. And there's also, case reports of it unmasking psychotic disorders and things like that too. On the other hand, high dose CBD is used in children with seizures. And we do have drugs like Epidiolex that's approved in the United States and Canada for childhood seizures that are unresponsive to normal drugs. CBD also can have interactions because it does affect the liver enzymes that are involved with clearing other drugs and medications. So I have seen people get the 4 Ds with CBD as well. And that's why it's so important to really have a professional work with you. And the latest side effect from cannabis really is the study that just came out in just over a month ago, where the researchers published on what's been happening in Canada since the legalization of marijuana with the Access to Cannabis for Medical Purposes Act, where we're allowed to grow marijuana. That was in 2016, August 24th, 2016. And then with the commercialization of marijuana, where recreational marijuana is now legal as of October 17, 2018, we now see that there's a 223% increase in traffic accidents from that. And unlike alcohol, where there was maybe a 9% increase during the same time period, and maybe part of that due to the pandemic. So I think the research is coming out. We've got to be careful with how we're using cannabis. And for me, to avoid crashing, the 5 commonest mistakes that are made by cannabis-naive patients is number 1, eating cookies and edibles and not realizing that it takes 1 to 2 hours for it to start working on your pain or working to make you feel more relaxed. And so you eat it, and unlike alcohol, which works fairly quickly, you don't feel anything, so you eat another cookie or another edible, a gummy, and then then it hits you, and you're driving and you get into an accident. Remember, the oral forms of cannabis can stay in your system from 8 to 12 hours. Regulations. Do not bring it across the federal border. You got to abide by workplace rules. A is automobile and machine operating. The latest guidelines suggest oral forms of cannabis. If you take an oral form, don't drive for 8 hours. If it's inhaled, don't drive for 6 hours. And look at the storage component. Keep it locked up away from your children, from your pets, so they don't end up in a merge. And if you don't seal it properly, it will degrade if you're using the herbal form, the plant form. And there's also a lot of hype as well. You've got to do your research. Get professional guidance from a doctor, nurse, or pharmacist. So one of the groups I've done a lot of work with, we published papers, is Apollo Research. And one way to get guidance is see a medical professional. On the team there, they have rheumatology and psychiatry specialists for more complex conditions.
Thank you, Dr. Ko. So you've talked a lot about many different emerging treatments tonight, and just given how quickly this field is evolving, could you just share a little bit about what is really exciting you about the future of arthritis treatment?
Well, one exciting study that was announced in September is there's going to be a randomized control trial to look at cannabinol. It's a derivative of the THC plant that helps with sleep, but without the stone side effects of taking too much THC. So cannabinol, there's a lot of hype about it, but we're going to see from this randomized control trial, does it work? And that's going to be a study that I'm looking forward to seeing as well come out. With Dr. Arsenault at his centers, he is looking at a German product that is now resurging called mistletoe, where you do injections just in the skin to really help with osteoarthritis pain. It actually has an effect on reducing cytokine expressions, the inflammatory cytokines, and with an 80% success rate, 17,000 patients treated based on earlier studies out of Germany. So we're seeing how that transfers over to what can be helpful in Canada here. There's also the role of topicals for osteoarthritis, everything from Salin Pass patches that you can get at Costco and BioFreeze that you can get at health foods, the pharmacies, to topical capsaicin. The American College of Rheumatology actually says we endorse topical capsaicin, which does stimulate the TRPV1 receptors and causes a burning sensation to sort of numb out the pain. They do endorse it for osteoarthritis of the knee, but not for the osteoarthritis of the fingers, because maybe you could get it in your eyes. They also endorse topical CBD for osteoarthritis of the fingers, but not the knees. So I'm teaming up with Jupiter Health.ca to really look at this in much more detail, and hopefully we'll have some research out for you. Another group I've been working with, Kintech.ca, looking at how shoe wear can affect the dynamics in knee arthritis instead of just bracing the knee or using orthotics. Shoe wear is just as important. And another study that was published 2 years ago, pain processing therapy. I learned about this from one of my patients who had 4 back surgeries. 3 years ago, she had surgery for thoracic outlet syndrome where they took her ribs out. She went through 9 years of treatment for chronic Lyme disease in the United States, always in pain. She says to me, Dr. Ko, I have no pain. And she's the one who launched looking at the pain reprocessing therapy, where they actually correct the loops in the brain that are caught in these circuits using techniques to train it. Non-drug techniques, but ways to approach it, including mindfulness meditation, things like that. So this is another area that we're really, really interested in, the neuroplasticity part. Studies are coming out and using this also for not just back pain, for knee arthritis and for rheumatoid disease. And I also have another patient who was healed by prayer. And she is now a professor at Trent University teaching nursing, and was really, really healed from her bad arthritis pain that was close to being surgical with Dr. Nima, who's a pain anesthesiologist who has that type of gifting. So we're looking at that as well too. And finally, the other research, exciting research area is that of injecting stem cells from your fat tissue, adipose stem cells, and bone marrow stem cells. 2 studies are going on right now that you can be enrolled in. The extension date has been extended beyond December 2023 to 2025. One group is in Kelowna with my colleague, Dr. Grant Pagden. You'll see his email contact there. The other in Toronto with Dr. Grigori Karmi, karmiclinic.com. If you hit that link, you'll get information on whether you're a candidate for being in a study using stem cells into your arthritic joints. And hopefully the outcomes will lead to Health Canada reapproving stem cell treatments for arthritis, which we've seen helpful in the past.
Mm-hmm. That's great. So we have had a number of questions come in. Before I get to those, do you have any final thoughts or recommendations that you wanted to share for the viewers?
Yeah, I think the big thing is we have to smile daily to lay a good foundation for our body to heal itself. SMILE stands for sleep 7 to 8 hours nightly. In fact, another genomic study showed if you sleep less than 6 hours, you're 1.5 times more likely to get rheumatoid arthritis. Plus, outcome mortality is higher. We've got to move right, and we have to, if we have trouble walking, get into aqua jogging. I know my colleagues and I, we would go in the pool and train with our patients, especially when I had my own surgeries and arthritic conditions. We have to inhale and meditate. Dr. Andrew Newberg's studies looking at neurotheology has found that if you can meditate 12 minutes plus a day, it reduces your risk for frontal lobe atrophy and dementia. So again, this is a foundation always taught by my physiotherapy colleagues who work with me as well, learning how to breathe properly. Loving and connecting. We learned from the blue zones, where people live the longest in the world. Now there's 6 of them, not just 5. And in Okinawa in Japan, where the women live the longest in the world, they have something called moes, where they have 4 or 5 really close friends who are there to support each other. Osteoarthritic hip and knee patients are 1.47 times more likely to be socially isolated, to be depressed because of that. So we need to connect. And finally, eating right, avoid ultra-processed food and eat more fresh, whole plant-based foods. They're the best. SMILE is what we need to do for the foundation for optimal health. If we all did this in Canada, our healthcare expenses will go down. The total risk from invasive surgeries and procedures will be reduced for our population and for each of us. And even if a hip replacement is needed, you will sail through it with fewer complications. And finally, don't smile alone. Find a nutrition group, for example, not a smoking cigarette group, to get better. Find a modality such as an exercise group on land or in water to make yourself stronger. Use it or lose it, but don't abuse it. And find an empowerment group where you can really support each other and really help each other get through the storms of life. This is the way to keep on track with your arthritis and autoimmune disorders. Having people keep you accountable, encourage you with what you're doing. And with the backups of, if we need higher up therapies, physiotherapists, functional medicine doctors, rheumatologists, and orthopedic surgeons, integrative medicine is the way to go to help ourselves and our country heal, our healthcare system heal. So that's it. Let's go to questions, Ashley.
Perfect. That's great. Okay.
There's resources here too, right?
Amazing. And we will share more after this session for sure. Okay, so we've had a bunch of questions about PRP that you talked about at the very beginning. So a few different things. First off, a general question, people, you presented some studies where there's some good evidence that it seems to be showing some success. So the question really is in different ways, why isn't it more established or used in practice? And maybe it refers to what you talked about at the very beginning about RCTs, but I'll hand it over to you to help us with that one.
Well, I think it's, when we started first doing this about back in 2009, it's, you get to see how things have really, really started to evolve. I have orthopedic surgical colleagues of mine now at even teaching hospitals in the University of Toronto who are doing PRP. They offer it as an option for patients to do, in addition to the cortisone and viscosupplement injections. So it's becoming more mainstream. But I remember that the earlier slide, there's this time lag where we need to get the studies published. And remember, no one can really patent your own blood. It's not like there's a pill where you've got a company that can, has a patent and they can spend millions of dollars to. This is all studies that are done really from the grassroots. Even the case study series I did, we had no support for it. We just did it on our own time, right? So we need more efforts, and we need my medical students to step up to the curb and help out with publishing studies as well too.
Yeah, that's great. So for people who are seeing some impact from these, how long would you expect the positive impacts of an injection to last for people?
Well, it depends on what you do before, during, and after the injections. And again, there are things that will interfere with the healing components of PRP. So if you optimize things, and it's a pure ligament type of issue, you could be like Ruth Grant and be pain-free, or not completely pain-free, but like able to walk, run, and do her tennis for 4 years later, right? There's always going to be some maybe mild discomfort, but it's tolerable. It's something that you can work with. Other studies have shown, there's controversy about, do we have to do serial injections? But the science is really getting refined now. Once we now are able to identify exactly the concentration of platelets, how much white cells are used, we can really be much more focused in doing better studies and getting better outcome measures. As a general rule of thumb, when I have people do PRP with me or with others, actually I don't do the injections anymore. I have it offloaded to the TIPS pain clinic in Vaughan, where my colleagues are able to do it under X-ray and better ultrasound guidance, and we do the prep work to make sure there's the markers for inflammation are down, like the SED rate, ESR, C-reactive protein are down. The vitamin levels, not just vitamin D, but vitamin C, iron levels, zinc levels, which are all key for tissue healing, are all at the higher quartile levels. We know that the body's in a good healing state. So getting people prepared will lead to better results.
Right. And could you talk for a moment too about potential costs and paying for these kinds of treatments?
Well, the costs vary. I know one hospital where its cost is subsidized by the hospital, so the nursing staff and the equipment is cheaper. So the cost is about $500 for the injections with PRP. Other places are about $1,000. So there's that type of range. When you do injections with viscosupplement injections, the cost for the product is about $500 as well. But again, a lot of that is covered by extended health insurance if you look for it under as a medical device. Yeah, if you look at it under drug, you won't see it there. It has to be listed as a medical device for viscosupplement injections.
Okay. So that brings me to another question. If you are a patient looking for different options and you're looking at the different types of injections, whether they're PRP or viscosupplementation, et cetera, how do you, like, as a physician, how would you recommend what path people take? What kinds of different things they could consider? I think people are just looking for a little bit of guidance around how to judge the different options.
Yeah. Well, I think, first of all, do the smile stuff yourself. Get your lifestyle habits in order. Right, that's something you don't need a doctor really to tell you. You got to start becoming aware of how to get your body into a better healing state, and you got to get off the ultra processed junk food, get off the fast food. One of the common things I see is people drinking diet pops all the time, and aspartame kills the cells in our brain, not only for memory but for weight control. So they drinking that pop, they get put on all this weight. For every 10 pounds of weight you put on above normal, you're loading the knee joint up to 40 pounds extra with each step. So you can see there's a big link with obesity and arthritis, especially in the knee joints. So you got to be working on that component. And then you need to, through your family doctor, get referred to a physiotherapist. If you haven't done physiotherapist, chiropractic, again, I'm very I prefer what I call our FCAMP physiotherapists, FCAMPT. The national organization is manippt.org. And these are the physiotherapists who have expert training in looking at the biomechanics, using their hands to even manipulate joints and the spine. And they can also do IMS acupuncture. And I find really good results with the guys who have that type of expert training. Same with certain chiropractors that I really find well working with. But you need to have an allied healthcare professional working with you. And I like to reference Dr. Klinghardt. He's one of the fathers of integrative medicine that I trained with back in the 90s. He has a 4-component model to help people with pain. There's the structural causes. So you need to have a good physiotherapist and maybe a physiatrist as well, like myself, to look at the structural areas of pain. And if it's really severe, where the joint's really badly damaged, then an orthopedic surgeon. So there's a structural side of pain. There's the psychological side of pain. So having a psychotherapist working with you, perhaps we need to get a psychiatrist involved if we need some medications, if the mood swings are really extreme. The third area is the biochemical side of pain. And this is where I like to use my rheumatology colleagues if things are out of control. But if they're not out of control, and even if they're out of control, I like to get a functional medicine doctor on board. Usually the guys in where I work are more naturopathic based, but there are medical doctors who are trained in functional medicine as well. And getting them on board to really help with the biochemistry of the pain. If you're overweight, a dietitian will help. A nutritionist will help to help you get your blood sugar down as well. These are all important features. And then for the neurological side of pain, looking at someone who can work on the neuroplasticity of the brain, where we have some advanced psychologists and other specialists who could really help with that area as well. So you have to find your team. You got to get a team to help you and your family doctor navigate through your chronic autoimmune disease and arthritis.
Great suggestions. So related to who you go to, you talked about a number of different blood tests that people can look at to understand what their baseline levels of various things are. Who would be the kinds of physicians or clinicians that people would be going to get those tests done or ordered?
Well, you always start with the medical doctor, right? And your family doctor. And usually family doctors, if they're thinking that you may have signs of autoimmune disease, lupus, rheumatoid, psoriatic arthritis, ankylosing spondylitis, and they will order other labs like the rheumatoid factor, the anti-nuclear antibody, anti-double-stranded DNA, the anti-ENA for Sjogren's syndrome. I find one that's often missed by doctors is the HLA-B27, and the HLA-B27 is a marker, a genetic marker that is seen in a high percentage of the population, but it is a risk factor for developing autoimmune diseases like seronegative arthritis, ankylosing spondylitis, psoriatic arthritis, colitic, Crohn's, ulcerative colitis, colitic arthritis, and Reiter's syndrome, right? So those are things that family doctors will, and if it's positive, you'll be referred to a rheumatologist to do more advanced testing. And if the ESR is really high, like the SED rate, Lee and I like to see it under 8, but if it's, and the lab will say under 30 is normal, but if it's like sky high, like 60, 80, even 50, my rheumatology colleagues will take over and put people on medications to really bring the wildfire down, right? Same with the C-reactive protein. The C-reactive protein is more a marker for inflammation in muscles and soft tissues. It can spike up high in infections. So getting that checked as well is also important. So those are key tests that are helpful. And then if you want to go beyond that and you want to go into functional medicine, you've got to be able to connect with a medical doctor trained in functional medicine who will go up a notch to look at other advanced testing that could be done. And so there could be a naturopathic doctor trained in functional medicine that works with a medical doctor, as Lee and I have worked for 15 years together. There's some functional medicine trained medical doctors in the GTA that I often will refer to as well, who are also very good and know their stuff.
That's great. We are almost at time, but I'm going to squeeze in one last question if I could, and that is we have a number of people who are interested in clinical trials. So could you give a little bit of guidance about how people would go about looking for clinical trials that they would be eligible for?
Well, I can talk right off because I've been updated on Grant Pagden's and Grigori Karmi's trials. So in Grant's trial in Kelowna, they're looking at moderately severe osteoarthritis in various joints, like the hip, the knee, shoulder. And if you have severe bone-on-bone arthritis, you're not an approved candidate. And what they do is they put people into 3 streams where they have the platelet-rich plasma injections done, platelet-rich plasma done with bone marrow stem cells, actually, no, sorry, not the first one. That's PRP with bone marrow, PRP with adipose stem cells, and then PRP with bone marrow, adipose, and combined together, all 3. So they have 3 arms. Everybody's going to be entered. Now, they've completed about 150 patients or so. The FDA, the NIH have approved them for 250 patients. So we expect it'll go on to 2025. With Dr. Karmi in the Toronto area, he's looking only at knee osteoarthritis, and with injections, all the injections are obviously done with guidance. And he's also including people with bone-on-bone severe arthritis in the study. So these studies are not free because there is a cost for the kits, the materials, and all the equipment that's involved with monitoring and tracking patients. So it's not a free study, but it's something that you'll be able to do with the blessing of Health Canada because it's approved as a clinical trial.
Amazing. And of course, Health Canada lists all their trials publicly. So that's wonderful information, Dr. Ko. So thank you so much for sharing all of your knowledge with us today. We would like to take just a few moments to get the audience's feedback, if we could, on the presentation. So for those of you who are watching on Zoom, you'll see a poll question come up on your screen with some options. So just do click on the response that reflects your thoughts. And the question is about, I feel more knowledgeable and empowered after attending this webinar. We will also be sending you an evaluation form when we email the recording and the slides. So if you weren't able to get to that poll question, you will have the opportunity to give us feedback at that time. And as I always say, we really do use the survey feedback to shape our future arthritis talks, and we value your input. So do take a moment to tell us what you think and what you want to hear about next. And once again, we are very grateful to Pfizer, United Way Winnipeg, and others for their financial support of this event. We will be back on November 22nd for Arthritis Talks, Biologics, Biosimilars, and JAK Inhibitors with Dr. Alan Lowe. So for more information and a link to register for that, you will see a link in tomorrow's email. So this concludes tonight's Arthritis Talks. On behalf of all of us, thank you for joining us tonight, and please stay well.